Go.
Well, good afternoon, everybody. We have a large number of people from all around the world joining this webinar. My name is Graham Beastall. I'm the past president of IFCC, and it's my pleasure to be the moderator of this session. I don't think anybody would disagree that laboratory medicine is of growing importance in healthcare. We are now very much at the center of the multidisciplinary team. And with that position comes responsibility to improve the quality of the laboratory medicine that we deliver. Now, every laboratory medicine specialist working in their own laboratory will be striving to do this, ultimately perhaps aiming towards individual laboratory accreditation. But as a profession as a whole, we also have a responsibility to improve our quality. We live in a world of global instant communication, and therefore the ability to harmonize what we do within countries and between countries is becoming an ever more important part of harmonization and improving quality. We're very fortunate in this webinar that we have probably the world expert on this topic that's going to deliver our webinar, and therefore it's a great pleasure for me to introduce to you Professor Mario Plebani from the University Hospital of Padova in Italy. And Mario is going to talk to us to the title Harmonization in Laboratory Medicine as a Global Picture, the request, the sample, the measurement, and the report. So over to you, Mario.
Graham, thank you for this introduction. Good afternoon to everybody. It's a pleasure to have many people around the world hearing from me. And I just start with the first slide, that is to introduce Padova University Hospital. The arrow show you where is my lab. But I like to invite you to visit Padova, to visit one of the oldest medical school and university in the world. And you will be every time very welcome to Padova. This is my lab. It's a mix of technology in a very historical building. But now it's time to go directly to the talk. And this is the outline of talk. I like to share with you some ideas about harmonization in laboratory medicine, the rationale, the drivers. I like to speak of vitamin D. And there are some papers dealing with the issue of the harmonization of laboratory test profile. As you can see, in the UK, a survey identified 11 different profiles for liver function tests, listed by among about 49 exactly laboratories. So, if it should be true that the ideal profile may not exist, such differences for sure cause confusion and affect patient safety. And thereafter, we have to work to provide guidelines and practical guidelines for blood collection, sample preparation, sample handling, and even transportation and storage. Very important pre-analytical issues. But for sure, the analytical standardization and harmonization is the core of the process of harmonization. And in fact, the definition of harmonization is, in the analytical phase, is a harmonization of measurements refers to any process that enables the establishment of equivalence or reported values produced by different measurement procedures for the same measurement. That means the quantity intended to be measured. And we usually are calling a test this quantity. Standardization and harmonization are both based on the traceability principle described in the International Organization for Standardization Standard 175 11, released in 2003. This standard includes 5 categories of reference systems. I'm sorry, this is the definition of standardization according to this document. Standardization, according to the term standardize, should be used when results for a measurement are equivalent and traceable to the international system of units, the Système International d'Unité, through a higher order primary reference material and reference measurement procedure. And vice versa, the term harmonized should be generally used when results are equivalent, either being traceable to a reference material or based on a consensus approach, but neither a higher order primary reference material nor a reference measurement procedure exist. And in fact, if you look at this document, there are 5 categories of measurement, and as you can see in this slide, only few measurement, category 1, present a true standardization because reference measurement procedures and primary reference material are available. As you can see, are some electrolytes, glucose, few hormones, cortisol, for instance. Vice versa, there are many measurements in category 2. This is the case for enzymes, for which the IFCC and other organizations provide reference measurement procedures, but we have no primary reference material, not available. For hemostasis, coagulation, we have sometimes reference method procedure, but not primary reference material as well. And in category 4 and 5, as you can see, that are protein, tumor markers, serological measurements such as Epstein virus, varicella zoster virus, and so on, we have no reference measurement procedure, neither primary reference material. So there are 2 ways to achieve harmonization. The first one is the hierarchical standardization according to the document provided by the International Standardization Organization. This is a top-down approach. We can do only if we have a reference measurement procedures and the reference materials available. In this case, calibration is traceable to SI unit. But the other way to harmonization is inter-method comparison. That is a bottom-up approach. Is possible and should be provided when we have no reference method procedure or neither reference material, high-order reference material available, and this should be performed through correlation method comparison on panels of human samples. So, I like to stress at this point, standardization and harmonization are clearly closely linked concepts, but are different. And sometimes standardization of assay does not lead to harmonized patient results, and vice versa, harmonization test results does not always require standardized reference methods. So, why sometimes standardization does not assure a true accuracy and harmonization for individual patient samples? Because measurement procedures may not be specific for the measurement. This is the case of interfering substances that may influence the results. And when measurement may not be well defined because molecular forms of clinical interest may not be clearly understood. And this is the case of many hormones, for example, and even for troponin I, or cytomegalovirus. So, metrological traceability is not enough because even for category 1 high order measurement, we should have problems due to measurement uncertainty and commutability. Don't forget we are working in patient sera, not in metrics different from human body. So, establishing traceability of results should be always linked to the definition of acceptable measurement uncertainty. That means fitness for purpose. And this should be clearly defined across the entire traceability chain, starting from the provider of reference material and finally to the data reported to clinicians by the end users that are the clinical labs. And I like to show you this paper from Mauro Panteghini, published in Clinical Chemistry, Laboratory Medicine, demonstrating that for serum albumin, for which we have a traceability chain, that means a standardized assay, today the combined standard uncertainty is not appropriate for the clinical purpose. The second point is commutability. Commutability means closeness of agreement between reference material and sample, patient sample. A commutable reference material may react in the same way as do patient sample when measured by different measurement procedures. But we know that it is not easy to provide commutability in laboratory medicine. Commutability, this is the case, a perfect commutability between clinical samples and the reference material. And in this case, correction factor is possible. And this should allow to achieve harmonization. But sometimes we are still using calibrators and other materials that are not commutable. In this case, patient sample results cannot be corrected, and harmonization is not feasible. And the problem we have today is that the many secondary reference material are not commutable with native clinical sample for routine clinical laboratory procedures. So today we know the measurement for which reference procedures exist or can be developed in the next few months or years are very, very few, the tip of the iceberg. And vice versa, most measurements for which no reference procedure exists or are likely to be developed in the next few years are most actually measured by clinical laboratories in the world. So what we can do, if it's true that several hundred measurements lack metrological traceability to SI units, this is a case of many immunoassays. This is a challenge we have. And we have two ways to standardize, harmonize, particularly immunoassays and peptide hormone immunoassays. The first one is to identify the biological active element and reduce this element to a substance of low molecular weight, and finally to develop primary reference material and primary reference measurement procedures. And this is a way successfully followed by the International Federation of Laboratory Medicine for the glycated hemoglobin, a great success, and now is moving for the CDT measurement. From another side, harmonization of available assay for heterogeneous antigens of family of closely related isoforms should be performed. This is for many analytes hormones. So, take into mind that the standardization and harmonization, particularly for immunoassays, should follow two ways. The first is a true standardization, and this is for small molecular weight proteins and substances. From the other way, for large molecular weight, we have to work on the so-called harmonization, and I will show you some example in the next few slides. What counts is that the measurement should or have to identify what is clinically relevant in the clinical practice. For example, it's very easy to define the calcium. Calcium is calcium. For parathormone, PTH, now we know that the amino acid 1 to 84 form is what we have to measure. And for vitamin D is the sum of the D2 and D3 isoforms. And for TSH is a mixture of glycoform that should be measured in a equimolar way. So now we know that according to this pragmatic point of view, we have clearly to improve the harmonization, even for measurements that are not, that we cannot standardize in the true way. So, harmonization should be viewed as a short-term interim solution. Is based on assay harmonization through the comparison on commercially available assay, and the results should be analyzed, produced by different assays, should be analyzed by the demi regression and compared with the overall mean. But now, particularly the group of Linda Tiempon provided the data with other formulas that are working better than the demi regression. There are papers published in clinical chemistry, laboratory medicine dealing with this point. And we can eventually correct the bias. I will show you now a practical example of harmonization from a paper published in clinical chemistry by the working group of the International Federation of Laboratory Medicine, the IFCC. Graham Bistal is an author of this paper, shared the authorship. You can see in the first part of the slide what was the situation before recalibration, and you can see below the after recalibration. The bias is minimized or completely zero. And you can appreciate in this slide the true values before the recalibration. I'm sorry, this is the slide. You can appreciate the different results, the different bias provided by A, B, C, and different available assay in the commercial market. And in the final part of the figure, at the bottom, you can see that the bias is completely minimized after the harmonization process. That means the recalibration according to the mean value obtained in a pool of human sera, well selected. And the same has been provided for insulin. I will show you the situation before harmonization, so the calibration according to the manufacturer's process, traditional process, in comparison to the reference procedure, measurement procedure, and moving toward the recalibration based on the mean value obtained in individual sera, at least 3 serum pools, and thereafter 16 individual sera, and finally 39 individual sera. You can appreciate the reduction of the differences between different laboratory, different commercially available assays. So harmonization does work. And I like very much this paper published in CCLM as the Prince harmonization finds the Sleeping Beauty, and therefore we can perform harmonization in our routinary practice. And this is a very feasible way to make our data more and more comparable between different procedures, and of course between and among different laboratories at an international level. So the final goal is the equivalence of measurement results among different routine measurement procedures over time and space according to defined analytical and clinical quality specification. And this was harmonization has been achieved in the field of protein through the development of an international calibrator. This is a work provided by a working group of the IFCC, and this is very effective in improving the standardization, harmonization not only of Cystatin C, but even more of many specific proteins. In the field of coagulation, you know for sure the importance of the international normalized ratio for harmonization of test results for prothrombin time. This was and is an effective way to improve harmonization. And even for many other parameters, D-dimer, in particular in this slide, you can see that harmonization is a very effective and practical way to improve the comparability between different assays and different labs. What about molecular diagnostics? Today, there is a lack of established and globally accepted reference material, so standardization is not possible up to now. But we need to have harmonization, particularly for some quantitative measurement through molecular biology. And harmonization in this field provides some advantages over standardization, particularly when biomarker assays are still exploratory, and the relevance to clinical utility is underway. So this is the case of translational medicine. Standardization in molecular diagnostics carries the challenge of new technologies. But what we need is to not only to standardize the analytical method, but to achieve consensus of indicators for harmonized specimen, measuring integrity, and data reporting. So, as you can see in this slide, harmonization should be applied to all assay variables in molecular biology and for the new biomarkers, starting from the protocol, raw data acquisition, processing, interpretation, reporting. And only in this way, comparison of data between laboratories becomes objective and supportive in this field of research. So there is no question about the final goal, to become equivalent for long-term results, and information must be traceable to high-order references. But while and if we have no reference material and high-order reference calibrator and reference measurement procedures, harmonization is an effective way to improve the comparability of our data and information. What about the post-analytical phase? In the post-analytical phase, there are many issues should be harmonized, and particularly reporting units, formats, reference intervals, reference change values, the so-called critical difference, decision limits, and even turnaround times and critical value communication notification. What about the units? As you can see in this line, there is an urgent need, not only in the UK, but in all countries, to harmonize the units used to report test results. And in fact, in this paper, our colleagues in the UK demonstrated the problem for patient safety and clinical interpretation errors due to the evidence that some labs in the UK, in the same geographical area, were still reporting hemoglobin concentration both in gram per deciliter as well as in gram per liter. This is a tenfold difference. So patient moving from one lab to another one should receive the data tenfold higher or lower. And this is a clear clinical risk. And this should be reduced very easy through harmonization. The results. It was realized in the same geographical area that labs using the same analytical platform and reagents use different reference intervals. And so the interpretation was not homogeneous and harmonized. I like to invite you to go to this website, pathologyharmony.co.uk. As you can see what they have done, a very practical approach to the harmonization of reference interval. In this case is potassium. And you can see as before harmonization, there were labs with the values lower than 3.5 or higher than 3.5 as minimum range level, as well as the labs using upper limit lower or higher than 5.3 millimole per liter. So they harmonize in this way, and they harmonize in this area even the reference range for high requested parameters such as urea, phosphate, albumin, total protein, and so on. A very practical way to harmonize very commonly used and requested tests. Reference interval. This is still an open issue, and we have to agree that inappropriate reference interval may impair the interpretation, the right interpretation of the data. And in this case, even the analytical standardization should lead to worse the patient outcomes, as stated in this paper. You have to be sure and to agree that reference interval obtained with analytical procedures that produce traceable results can be transferred between laboratories. So we have to use the same traceable reference interval in populations that have the same geographical characteristics, that is gender and race characteristics. There are some papers dealing with this point. I'd like to invite you to give a look to this paper published in Clinical Chemistry Laboratory Medicine in 2012. How we can obtain reference interval traceable to reference measurement systems. Today is possible. Another post-analytical issue is harmonization of critical values practice. We know for sure the definition of a critical value. This was given by George Lundberg many years ago. And critical values are very effective to save patient life and to improve the quality of care. But unfortunately, as you can see in this slide, the critical values policies are vary a lot, not only in Italian institutions. This is a comparison with the U.S. situation. These are the limits, the low and high limit for critical value for potassium. And this is absolutely an unacceptable range of wide range of limits. Unacceptable. So there are today a good way to report critical value through the electronic or computerized systems. This is what we have published. And I like to stress this point. Automated notification, and in any case, the notification of critical values according to the results of our recently published paper, we found that notification critical values led to a change of patient treatment in 90% of patients admitted to surgical, 98% in patients admitted to surgical wards, and in 90% of patients admitted to medical wards. So a high impact in changing the treatment of patients. And only in 50% of the case, the critical values were in some way expected by the clinician. So in 55% of the case, the critical values were totally unexpected, and they should save the life of our patient. Very important issue. So I like to stress this point. There are some papers dealing with harmonization as a complete picture. You can download for free this paper published by me in Clinical Chemistry Laboratory Medicine in 2013. But not only. There is a special issue totally devoted to the topic of harmonization in laboratory testing, published in Clinica Chimica Acta last year, with many papers dealing with different aspects of harmonization in laboratory medicine. So, there are several approaches dealing with the complete picture of harmonization. And I like to emphasize the quality of the work performed by the International Osteoporosis Foundation together with the International Federation of Clinical Chemistry Laboratory Medicine in the field of bone marker for osteoporosis, in general bone marker turnover. What they have done is they explain the rationale, so the identification of the most important clinical application, very important issue. They selected some reference bone turnover marker, 2. They tried to standardize the available data through the development of reference measurement procedure system, but they also provided suggestion for an interim strategy of assay harmonization involving comparison studies between different routine clinical assays. I mean, commercially available assays. Very important point. As well as the evaluation of pre-analytical sources of variation control. They performed some studies on the analytical control rules, that means internal quality control and external quality assurance schemes, and finally provide data on the reference population databases to provide the right interpretation of the data. So, the criteria for the selection of bone turnover markers have been clearly defined by the working group I already explained to you, and according to the work they have done, we know This is a slide I can highlight now, is that they identified 2 reference bone turnover markers. So there is a list of possible bone turnover markers, but only 2 are today recommended. One is a marker of bone resorption, is a so-called C-telopeptide, CTX, serum peptide, and another one for bone formation, as a marker of bone formation, that is the type 1 procollagen C-terminal propeptide. Very, very effective recommendation. And they provide the way in which we can standardize the assay, but up to now we can harmonize. There is for both the 2 markers, they provided some guidelines. So in this case, the harmonization process started from the beginning, selection of reference bone turnover markers. That means the appropriate test that should be a request. Evaluation of pre-analytical social variation in the pre-analytical phase to provide quality in the collection and handling of samples, analysis, harmonization of available assays, analytical control practice, results interpretation, because they provide a reference database for comparing the analytical results with the appropriate reference population databases. So, harmonization is a global picture. There is another field in which we have worked under the umbrella of the IFCC, is the field of quality indicators. Quality indicators are very important to document and improve all the processes and procedures in the total testing process in laboratory services. So I like to remember you that implementing quality indicator is a must for the accreditation of clinical laboratories. This is clearly defined in the international standard 15189. That is the unique international standard for medical laboratory accreditation. And there are several programs around the world on laboratory quality indicators, we have developed a project, and I like to invite you to take a note of the website www.ifccmqi.com. In this website, you can have all the information on the harmonization quality indicator, because we have organized a consensus conference in 2013. And so in the website, you have a list of harmonized quality indicators that currently are evaluated by many, many laboratories around the world. And we are searching for champions in every country to improve the number of laboratories that are attending this project. There are 2 main advantages. It's for free, nothing to pay, and the data are treated in a confidential way. So you know your data, and you may compare your own performance with many, many laboratories around the world, but no other than you should know the data of your own lab. So we are moving to the final part, the roadmap for harmonization. We need to implement a systematic approach to harmonization. First of all, we have to identify the measurements for which harmonization is needed, but we have to prioritize the measurement based on clinical importance. for instance, troponin is very important, and the IFCC is doing a great effort to improve the standardization, harmonization of troponin. The second one is the technical feasibility. And finally, we have to organize the implementation of harmonization activity around the world at an international level. So this is a scheme provided by Greg Miller on behalf of the American Association of Clinical Chemistry for the harmonization process. And according to this view, we have to involve in this process of harmonization international clinical and medical organizations, as well as IVD manufacturers, clinical laboratory, first and foremost, but even metrology institute, standard setting organization, and regulatory agencies. So we need the collaboration between and among several stakeholders. And this is the website of the International Consortium for Harmonization of Clinical Laboratory Results that started on behalf of the AICC. It's very useful to go to this website to have more and more information on harmonization program around the world. And I like to stress that laboratory profession can and should play or must play a leading role in promoting the implementation of harmonization. Another very, very important issue is the role of proficiency testing and external quality assurance program, because in this program we have to use commutable samples, and if we are using commutable sample, harmonization of data through the knowledge of the bias is feasible and should improve the comparison of the data and the information among different laboratories around the world. So take a note that this is a very important point. So harmonization is a three-level process. At the local level, we have to harmonize laboratory practice, particularly regarding units and reference range. We are doing this in my region. We would like to move to the same unit per liter for all laboratory tests, starting from troponin, hemoglobin, and many, many other biochemical and hematological measurements. At the national level, we have to provide process and program to improve or to develop laboratory practice regarding communication test results, including critical values, and a very important work and duty of national society is to spread the information about internationally developed guidelines. At an international level, standardization and harmonization methods program should be more and more activated and developed, and guidelines released. So, we are moving to the final part, take-home message. The first take-home message is harmonization initiatives have a central role in laboratory medicine, an increasing central role in laboratory medicine, and require input from a range of national and international stakeholders. But laboratory professionals have a key role, of course. Harmonization initiatives should take into consideration all steps of the testing process, not only the analytical part, and should include appropriateness in test and request, units, and procedures, even in the post-analytical phase. So, harmonization as a global picture should include all aspects, starting from the right test choice at the right time on the right patient, moving through the analytical steps to achieve the right results in the right form, and finally, to to the post-analytical phase to provide the right interpretation, eventually with the right advice as to what to do next with the results. So, standardization harmonization in the analytical phase does not require traceability to the standard unit per se, and it does not require the use of particularly sophisticated methods such as mass spectrometry. As I said to you, we can harmonize the data through the comparison of commercially available assays using panels of well-selected panels of human sera. And the development of harmonization initiative require close interaction, once again, of all stakeholders. So, I hope that after hearing from me this webinar, you can agree with me that harmonization is not only the harmonization of data, results, analytical results, but we need to harmonize names, patient preparation, specimen collection and handling procedures, as well as reporting units, reference ranges, and interpretive information. So this is what we have to do, not tomorrow, but today. And I'm sure that you agree with me that harmonization is an absolute priority for public health, as our customers, both doctors and patients and users, citizens, expect today that laboratory results are equivalent and interpreted in a reliable and consistent manner. We cannot say to the users and patients that they must go always to the same lab, and that the lab should perform the procedure with the same procedure over time. We have to provide interchangeable information. However, and I like to finish, harmonization is not an easy task. And the English language is not easy. And I hope that Graham should agree with me. Why? Because you know that in the UK, they are using harmonization with the S, and vice versa and this is always the same in Canada, United Kingdom. But in the US, they are using harmonization as Z. So please, first of all, decide if we have to use harmonization or harmonization. Thank you so much for your kind attention, and I'm ready for questions eventually and comments. Thank you so much.
Well, Graham Beestall here again. Mario, thank you very much on behalf of all of the people that joined the webinar for your very comprehensive and very clear description of harmonization. And in particular, I was pleased that you highlighted that we need to have effort at harmonization at local level, at national level, and indeed at international level. It's the responsibility of all of us working in laboratory medicine to play our part. And you've given us a clear description of how we can actually do that. So I don't know if there's such a thing as an electronic applause, but electronically people will be clapping to thank you very much for your presentation. Now, if people want to stay online, we can deal with questions. I understand from Enrique that you should be using the chat facility that's there to ask any questions, and we can relay those to Mario, and he can try and deal with your questions. At the moment, I don't know if Enrique can hear me, but I'm not sure that we've actually got any specific questions. Enrique, are you there?
Graham, let me say that I have to thank you because many suggestions, recommendations, and input were from you. So thank you so much.
No problem. It's a pleasure to facilitate. Enrique, you're there, yeah?
Yes, I'm here.
Do we have any questions yet?
No, until now we don't have any. So I'm checking the chat, but until now it's okay. I think that everybody understood quite well Professor Plebani, so no problem at all.
May I ask you if the way in which I presented the slide, I mean the simultaneous movement, was good?
Yes, it was fine. It was very good. No delay between slides and.
Oh, this is very important because I didn't see the slide. So thank you so much for your cooperation. We worked a lot to provide a good standard of this webinar. Thank you so much, Enrique.
Okay, we thank you very much, Professor Plebani. It was an excellent presentation. And
thank you.
You, Graham, thank you very much for accepting to moderate this session. Okay, thank you.
It's been a pleasure, and I guess we just declare the webinar closed. Yeah.
Yes, I think so. Thank you very much to all.
Thank you, Graham. Thank you, Enrique. See you, Enrique, tomorrow in Proctor.
Of course.
Yes.
Okay.
I'm waiting for you. Thank you.
Goodbye.
Ciao.
Goodbye.
Bye. Thank you.
Alla Nuria.
Vocês viram a importância de standardização dos métodos a nível laboratorial. E vocês viram que só com os métodos nós conseguimos fazer standardização, ou seja, ter um método de referência e ter material de referência.
Ah? Não. Foi